7 of Robbins' 9th edition, and that is Neoplasia, and that begins on page number 266. The only objectives of today's lecture are that at the end of the lecture, the students will be able to discuss, they should be able to define neoplasia, classify neoplasia, discuss nomenclature of neoplasia, and discuss morphological aspects of various benign and malignant tumors. Some important tumors, of course, because at your level you don't need to go into the too much detail of it. So, before moving ahead, we need to revise histology. If you're going to study the morphological aspects, especially the microscopic morphological aspects of neoplasia, you need to revise the histology. You should be very good at histology to identify the pathology. So let's begin with the histological revision of it, and it is that if you're here in the scene, you're seeing a slide of histological slide of stomach, fundus of the stomach, and just to revise that it has 4 layers. From the top, it begins with the mucosa, and from the epithelium. Mucosa, which consists of epithelium. Remember that the mucosa and epithelium, they actually face the lumen of any organ. If we're talking about respiratory tract, or if we're talking about the GI tract, any of the tract, the epithelium is the boundary wall that is facing the lumen of that organ. And the epithelium is the topmost layer of the mucosa. As you know, it has 3 parts. Mucosa itself. It has the second part below the epithelium is the propria, and then muscularis mucosae. As soon as the muscularis mucosae ends, there is submucosa. And submucosa is basically the hub of the connective tissue, including the fibrous tissue, including the collagen, including the blood vessels, the nerves, and lymphatics. Below the submucosa is a muscular layer, which is muscularis externi, and last but not the least is a serosal layer, which is below the muscularis externa, and the serosa forms the outer boundary of that tract or any of the tract in the body. Another picture of the mucosa showing a gastric area where you can see the epithelium, which is converted into gastric pits because it has secretory activity, and then you have, this is the mucosal layer in which you have, we know that it has 3 parts, the top epithelium, and the propria, and muscularis mucosae. So, since it is from the stomach and it has secretory activity, this mucosa also has glands. And then there is muscularis mucosae, which is a thin layer of muscle layer lying beneath the mucosa. Below that, there is submucosa, which I already mentioned. It is composed of the fibrous tissue or the connective tissue. Okay, let's begin with the introduction of this chapter. What is neoplasia actually? It is cancer. You have multiple times seen the cases or heard this word, but what it is actually? The first time in the history of the world, the cancer was identified in Egyptian times when they found some growth and tumors growth, and they thought that it spreads around the body. This is a kind of a disease which kills people, it spreads in the body, and then eventually the person dies. Time passes, and then comes a Greek era, in which Hippocrates was the first person who used the word carcinoma or carcinoma at a time. Which was derived from the animal crab. Crab is a person whose venom spreads throughout the body and a person dies. So they thought that it is this disease, carcinoma or carcino is similar to the venom of the crab. And obviously we know that the crab is another name for cancer. So this is how the cancer word was derived. So cancer is the second leading cause of death in the United States, and it is not one disease, but it involves multiple pathogenesis, and it may be curable and it may be non-curable. You cannot always say that there's a hard and fast rule that the people with cancer cannot survive. or they cannot completely get rid of the disease. Now we've seen exceptions and we've seen both cases. Vocabulary of when we go through this chapter and we hear the lectures, there are certain terminologies that you have to be familiar with. Otherwise, it will not be easy for you to understand the mechanisms of pathogenesis and morphology of this disease. So, how cancer progresses? Cancer progresses before understanding the pathogenesis or mechanism of cancer progression. We need to understand how our normal cell divides in the body. So, imagine that this is a normal tubule cell in the body, and it obviously has to multiply. We know that there are almost every organ in the body except for some stable cells, all the cells divide. So when they divide, the parent cell dividing into the daughter cells. The daughter cells have to resemble exactly like the parent cell in the shape and the architecture as well as in the function. And when the daughter cell resembles the parent cell, we call it a well-differentiated cell. Well-differentiated cell means that it has close resemblance. The daughter cell has a close resemblance with the parent cell, both in functions and architecture. And when there is multiplication of these cells, further multiplication and division of these cells, we call it a uniform cell growth. And it occurs in all healthy individuals. It occurs in all of us, in our skin, in our GIT, in our lungs, in our mouth mucosa, anywhere. So this is a normal cell division. But when we talk about cancerous cell division, the architecture, the daughter cell will definitely differ from the parent cell in both morphology and as well as architecture. The parent cell has to undergo uncontrolled cell division. The cell division does not, cannot be stopped, cannot be controlled by the normal mechanisms of the body. And then you can see in this picture that the cells, the daughter cells or the subdivided cell, they do not resemble in architecture as well as morphology to the parent cell. Each individual cell is different in its morphology, the gross morphology as well as microscopic morphology. And that's why we call them gamete cells. Remember that these cells also not just differ in the size or the shape, but also the function. And similarly, the changes does not occur in the individual cell structure or the cytoplasmic content, but also the nuclear changes are very marked. We'll see and we will read as we go through. We will learn more. So neoplasia literally means new growth. New growth, as I explained to you why it was called cancer in the history and why it was. So basically, neoplasm is nothing but a new growth. Now, this new growth can be dangerous, risky, harmful, and non-harmful. So the tumor is kind of a swelling which refers to neoplasm, and it actually is, any swelling, as you studied in information chapter, the swelling actually refers to tumor. It was a Greek word. But then later on, the tumor was confined to cancerous growth or neoplastic growth. I would say neoplastic rather than cancerous growth. So oncology is the study of tumor or neoplasms. Again, a Greek word. Now, British oncologist Willis defined and gave us a definite definition of neoplasm or neoplasia. A neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissue. This definition has two parts. The first part tells you that a neoplasm is an abnormal mass of the tissue, is an abnormal growth, abnormal structure. The second part is that the growth exceeds and is uncoordinated. I will just explain to you in that picture. It is uncontrollable. It is beyond the control of the human body. The mechanisms which control the senescence and the apoptosis and the cell cycle that controls the normal mechanism or the normal multiplication of the cell, these growth, the neoplastic growth is uncontrolled by those mechanisms. What is the third part of this definition? That impulses in the same excessive manner, even after cessation of the stimuli which is the change. So, if a tumor grows continuously in the body, because of some stimulation that is being provided within the body, even outside the body. Say, for example, lung cancer that is developed due to in a smoker due to heavy smoking. Even if you stop smoking at that stage, if the tumor has been developed, it will continue to grow regardless of cessation of smoking. This is what it means. Now, what are the components? The neoplastic cell are the components, yes. And actually, the neoplastic cell refers to the parenchyma of that particular tissue. How you will see. And then there is reactive stroma that develops in a tumor. And the reactive stroma is made up of connective tissue. It is made up of blood vessels. It is made up of lymphatics. And it can also include the cells of innate and adaptive immunity. Classification of tumor and their biologic behavior are based primarily on the parenchymal component. So you have to be very sure and very confirmed about the parenchymal component of that particular tissue. Let's come to the nomenclature. We call a tumor benign or malignant. Benign, which does not risk, which is not harmful. It is there, but it is not causing any harm to the body. Malignant, it's cancerous. It's going to invade the tissue. It's going to affect not just the particular organ, but it's also going to affect the invade and go into the surrounding tissues and neighboring tissues. And then, why it is malignant? Why it is harmful? Because it invades the blood vessels, and through the blood vessels and lymphatics, it may reach to the distant part of the body. And that's how it spreads. So benign versus malignant tumor, the difference is very crucial and you have to see. Okay, the normal cells and the benign tumor cells. Some variation may be present in the benign cell, but it usually resembles the normal counterpart or the normal tissue cell that it is arising from. So benign is a tumor cell grow only locally, first point. It cannot spread by invasion or metastasis, 2 point. And the third, that it is well differentiated, that it resembles the normal cells. We use the word well differentiated. Talking about malignant cells, comparing it to the normal cell, they vary markedly in the morphology when it is compared to the normal cell morphology. It is bigger, the nuclear cytoplasmic ratio changes. Normally, the nuclear cytoplasmic ratio is 1:4, that is 1 part nucleus and 4 parts of cytoplasm. But you will see marked enlargement of the nuclei, different chromatin morphology, and a lot of mitosis taking place because they rapidly multiply. So mitosis means that this tumor is multiplying at that time. Cell division is occurring. Then the other important point is that they do not exactly resemble the normal counterpart or the normal tissue which it is arising from. So they are dedifferentiated cells. Other points are that they can invade in neighboring tissues. We already studied that. They can enter the blood vessels or lymphatics to metastasize, that is, to spread the different parts of the body and to distant sites of the body. So it is a normal cell, stratified squamous epithelium. And when you see a tumor arising from a stratified squamous epithelium, it is forming a mass of the tissue. It is overlying it. It is arising from the epithelium, but the cells are not resembling the normal counterpart, that is, they are dedifferentiated. So, how do they grow? Benign tumor, they are extensile. They grow bigger in size, they make huge masses, but they are usually confined by a capsule. So whatever growth is taking place, it takes place within the capsule. But when you're talking about malignant cells, the malignant cells, first look at the cell architecture, they do not resemble. And the benign tumors, the important part is that they remain within the basement membrane, they never break the basement membrane. Malignant cells, to spread and to invade the tissue, they have to break the basement membrane. And if you remember breaking the basement membrane, please recall the architecture of a stratified squamous epithelium. I'll show you pictures and then it will be more easier for you to capture. So let's summarize again. Benign tumors are slow-growing tumors. They do not multiply fast, so you will not see a lot of mitosis in them. Coming to the malignant tumor, they are fast-growing, so a lot of mitosis. Benign tumors are capsulated. Malignant tumors are usually non-capsulated. And even if they are capsulated, you will find a lot of broken capsulated areas. Broken areas of capsule in the tumor. Benign tumors are non-invasive, that is, they do not infiltrate the surrounding tissue, while the malignant tumors do. Benign tumors do not metastasize, that is, they do not invade the blood vessel or infect it to spread to the distant side of the body, while malignant tumors metastasize. Benign tumors are well differentiated, that is, they resemble closely with the normal counterpart. While malignant tumors, not all of them are poorly differentiated, but they are differentiated. That is, they vary from well differentiated to poorly differentiated. So benign tumors pronunciation, we use a suffix "oma." That is, for example, if a tumor is arising from a fibrous tissue, we use the word "oma." We attach the suffix "oma" and it is known as fibroma. While in malignant tumor, we use the suffix "carcinoma," that is fibrous carcinoma, or fibrocarcinoma, fibrosarcoma. We use the word adenocarcinoma or fibrosarcoma. Okay, so the suffix carcinoma and sarcoma are used for malignant tumors. So, some more terminologies. Clonal. Clonal is a word that is derived from colony. The colony of a cell is derived from a single organism or cell. That is, for example, if it is an adenocarcinoma, the cell is being derived from the glandular architecture. And it is derived by asexual reproduction, that is cell division. There is no sexual division occurs. All having identical genetic construct. The very important part is of a clonal of a cell, of the colony of a cell, they do not simply resemble in architecture or morphology or appearance, they also resemble in their genetic makeup. So a colony of a cell, say for example RBC, when you see the RBC of a cell and you take a RBC from the other side of the body, say for example one from upper limb, the other from lower limb, the architecture of the cell needs to be having the similar genetic component as well as similar protein component, similar architectural component from if it is taken from anywhere in the body. This is what a colony means. Now progeny. We all know that progeny means offspring cell or descendants. Desmoplasia, you will find and see a lot of desmoplasia in the malignant tumors. And the malignant tumors that form and develop fibrous tissue. So when there is a hard tissue, fibrous tissue within the tumor, we call it desmoplasia. And it is one of the features of malignant tumor. Sclerus. Sclerus is further one step ahead of desmoplasia, and in this tumor becomes stony heart. Now, we use the term gross. Gross means the naked eye examination, that is microscopically, and then there is a microscopic examination of the tumor. So you have to examine the tumor at two levels. One with the naked eye examination, that is gross examination, and the second is microscopic examination. And I have already explained to you what is metastasis. Metastasis is the distant spread of the tumor cells within a body. Now, cell division is very important, and just to give you a recall of it, what are totipotent cells? Totipotent cells is the ability of a cell to differentiate into any kind of cell of the body. Usually, and most importantly, these pluripotent cells are found in the fertilized ovum because the fertilized ovum has to produce the new progeny, a new human being. And all kinds of cells are required to produce a human being. So, the fertilized ovum is a hub of pluripotent cells. Now, there is another term which is pluripotent. So, how a pluripotent is different from pluripotent cell? A pluripotent cell is also capable of differentiating of any type of tissue, except the placental tissue. A pluripotent cell cannot form placental tissue. See in this picture, this is a fertilized ovum, and here is a hub of pluripotent cells. When it forms embryo, it also forms placental tissue and all. But later on it forms blastocysts, and blastocyst is an example of pluripotent cell because it has no placental tissue component. And then the cultured stem cells, you can culture it, and then these stem cells which we are using these days, the stem cell therapy for treatment of many of the diseases like osteoarthritis and rheumatoid arthritis and hair regrowth on the scalp and so many things. So we use these stem cells from the body, culture them in the laboratory, and then we can produce the progeny in the form of blood cell, in the form of whole cell, but they cannot form placental tissue. Coming to the multipotent cells. Now, multipotent cells are those cells, say for example, they can be grown in a culture medium, and they can grow into different kinds of specialized tissue cells. For example, if we take a stem cell from the brain, it will grow the neural cell. If we take a multipotent cell from the bone marrow, it will develop all cells of the blood lines. So these are multipotent cells. Now, multipotent cell, the definition is that relating to a stem cell, it is related to a stem cell, but it is capable of differentiating into a limited number of specialized cell types. For example, multipotent stem cells in the bone marrow that can give rise to red cells, white cells, and platelets. So clonal expansion is very important when you are studying neoplastic growth. Clonal expansion tells you that a particular cell will produce a specific type of clone. That is a B cell, that is one of, if it undergoes clonal expansion, suppose it is a tumor, and abnormal B cells are being produced, then it could be a tumor composed of B cells or maybe plasma cells only, but you won't find T cells clonality in that. So, but in normal cells, say for example, if a B cell undergoes clonal expansion, it is going to form plasma cells. We know why, because B cell always produce plasma cells as we have studied in immunity. And the function of the plasma cell is to produce specific antibodies. Similarly, T cells provide protection against the viral cells. So they will produce interferon, and then they will produce cytotoxic T cells, and they will eventually kill the virus infected cells in the body. This is called clonal expansion. Coming back to the benign and malignant tumors. First, the benign tumor. The tumor is said to be benign, and it grows some microscopic features are considered relatively innocent. They are relatively innocent because they do harm the body. They can produce pain. They can produce pressure effects. But since they do not have those aggressive aspects to them, they are not going to kill a person. So they remain localized, they will not spread to distant sites. They can be surgically removed because they are usually encapsulated, so they are easily removed through surgery. And then they can cause significant morbidity, as I told you, that they can cause pain and nerve pressure effects and all, but still the patient survives. For the reason thyroid tumors, coming with benign tumors, as I explained to you, that we add a suffix oma. And it is very important to remember the name of the tumor because this is what the classification of tumors is all about. So when we talk about the prefix and a postfix, suffix, so when it is a tumor that is arising from the fatty tissue, we call it lipoma. Coming from the bone tissue, it is osteoma. Fibrous tissue, fibroma. Cartilage, chondroma. Blood vessel, angioma. smooth muscle leiomyoma, striated muscle rhabdomyoma. Remember that you have to remember this classification by heart. A lot many times that they ask you in the exam or maybe in the test or anywhere, they come from this classification, major bulk of your questions. So you have to be very clear about how to classify them. Nomenclature of benign epithelial tumors is more complex. They are classified based on the cells of the origin, either cell of the origin or the microscopic pattern or the microscopic architecture. So coming to the neoplasm nomenclature, this is a short form, and then you have to recall, you have to remember all the names that is given in your book. That is Robbins. So the cell of, if it is a glandular epithelium, cell of origin, then the benign tumor will be known as adenoma. And the malignant counterpart of it will be known as adenocarcinoma. If it is coming from a lining epithelium, say for example squamous epithelium, then the benign tumor will be known as papilloma or squamous papilloma, and the malignant counterpart will be known as squamous cell carcinoma. If the cell of origin is fibroblast, then benign tumor is fibroma and malignant is fibrosarcoma. Remember that all the mesenchymal tumors are known as sarcomas, and all the epithelial tumors are known as carcinomas. So since it is a mesenchymal tissue, osteoblast, the benign tumor is osteoma and the malignant is osteosarcoma. Chondrocyte, that is cartilage cell, benign tumor is chondroma and the malignant tumor is chondrosarcoma. Lipocyte is a fat cell, benign tumor is lipoma and malignant is liposarcoma. Smooth muscle cell, benign tumor, leiomyoma, malignant leiomyosarcoma. Skeletal muscle, rhabdomyoma, and the malignant counterpart is rhabdomyosarcoma. Okay, I marked this table star. Why? It is the most important table that I have to learn from this chapter. The tumors of mesenchymal origin, as I have already explained, fibroma, lipoma, chondroma, osteoma, and their malignant counterparts in the same manner. Blood vessels, hemangioma, angiosarcoma. Lymph vessels, lymphangioma, lymphangiosarcoma. Mesothelium, benign fibrous tumor, mesothelioma. Brain coverings, meningioma, invasive meningioma. Blood cells and related cells, if they are coming from hematopoietic cell, there is only malignant cast tumor in it, and it is known as leukemia. And if it is coming from lymphoid tissue, then it is known as lymphoma. Coming from the muscles, if it is smooth, then we know that it is leiomyoma and leiomyosarcoma. Coming from the striated muscle, it is known as rhabdomyoma and rhabdomyosarcoma. Now, the tricky ones are epithelial origin tumors. If it is coming from stratified squamous epithelium, the benign one is known as squamous cell papilloma, while the malignant counterpart is squamous cell carcinoma. Basal cells of the skin are adenophila. The only malignant tumor is basal cell carcinoma. Epithelial lining of gland. As I told you, whenever you hear or see a picture of a glandular architecture, then it is adenoma and adenocarcinoma. Papilloma, papillary carcinoma, a cyst adenoma, and a cyst adenocarcinoma. I show you pictures and then you will be very clear about why they are called so. Expected passages, since it is again of epithelial origin, then it is bronchial adenoma and bronchogenic carcinoma. Renal epithelium, since it has tubules, so it's renal tubular adenoma, and malignant is renal cell carcinoma. Liver cells, hepatic adenoma, hepatocellular carcinoma. Urinary tract epithelium is a transitional cell epithelioma and transitional cell carcinoma. The central epithelium forms identical mole, and malignant counterpart is choriocarcinoma. Coming from the testicular epithelium, the malignant tumors are seminoma and embryonal carcinoma. Coming from the melanocytes, that is melanin containing cells of the skin, the benign tumors is known as nevus, that is a simple mole that most of us have, and the malignant is malignant melanoma. More than one neoplastic cell, not that there are mixed tumors also, in which there is more than one type of cell present. The classic example of it is salivary gland tumor, which is, if it is most of the time it is benign, it is known as pulmonary adenoma, and it is a mixed tumor of salivary gland region. While in the malignant case, it is a malignant mixed tumor of salivary gland region. The renal is large, coming from the renal enlarged with mixed type of cell population. The malignant tumor is Ben's tumor. Now, there are other types of tumors in which tumor cells are derived from more than one germ cell layer, that is ectoderm, endoderm, and mesoderm. So we call them teratoma, and they are actually coming from pluripotential cells in the domains. So they are known as teratoma, and if they are benign, they are mature teratoma, and they are known as benign cyst. And if they are coming from the malignant, cell components, but they are malignant and they are immature teratoma, teratocarcinoma. I try and show you a picturesque explanation of all these important tumors so that you have a very good idea. And if you don't understand in the first go, please read the chapter after listening to this lecture and then re-listen to this lecture. And I can assure you that you will have a very good concept of neoplasia. If you do it this way, first listen to my lecture, then read it through the book, and again listen to the lecture. And then even if then you have any query, you can text me back. So coming to the classification, since I've already gone through it and I'm going through it, you can read it up here. It's almost similar, just highlighting some of the important terms. So what is an adenoma? I just explained to you that any tumor that is arising from a glandular epithelium, it has to, prefix, it has a prefix that is adenoma. If it is benign, then we will call it oma, that is adenoma. Benign epithelial neoplasm derived from glands, although they may or may not form glandular structure. So what is a glandular structure on a microscopy? Are you seeing this gland? It has to have a lumen, it has to be surrounded by epithelial layer. If you find this kind of, and this is a basement membrane, that they are having a nice basement membrane inside, it means that it is a benign tumor. So you have to see the basement membrane in each individual gland. Okay, so this is an adenoma. Again, another picture of adenoma, you can see that it's a glandular, probably a gastric tissue slide in which you see lots of glands, but they are all intact. They are all lined by the lumen. The lumen is lined by epithelial cells, and they are eventually all finally very nicely bounded by basement membrane. So it is a benign adenoma. What is papilloma? Remember the word finger-like aortic projections. You must have seen words in the body or in some patients. So they are like finger-like projections. Alright, this is the gross architecture of the aortic or papilloma. You can see that there's finger-like projections. A very irregular surface, but they are benign since they are omas, right? They are coming from the epithelial surface, that is mostly from the stratified epithelium. Now you can see these finger-like projections, okay? And these have central fibrous core, but this, if you go on high focus, then you will find that they are lying the stratified epithelium. Now coming to the cyst adenomas are the large cystic masses, and in the area are referred to as cyst adenoma. Whenever you see a large spaces like empty spaces of like a cyst, we call it cyst adenoma because it has to have certain glandular component also. So cyst is for the large spaces, adenoma is for the glandular component, and oma is for the benign counterpart. And usually they are found in the ova. We call them cyst adenoma. Now coming to the other tumors, some tumors produce papillary pattern that protrude into the these are the papillary patterns. They are protruding into the lumen of the cystic space, and we call it papillary cyst adenoma. Because papillary is for the papillary projection, cyst is for the cystic cavity, adenoma is for the glandular component, oma is for benign. A polyp is a neoplasm that has a grossly visible projection into the lumen above any mucosal surface. A polyp can be found anywhere, but usually they are found within the hollow vessels, not the vessels but the hollow organs like GIT or like, respiratory tract or cervix, etc. So any grossly visible projection above the mucosal surface, and it actually projects into the lumen, even a gastric lumen or colonic lumen. It is known as polyps. I'll show you some pictures. This is the mucosal surface, and it is in both overlying the mucosal surface. It projects above the mucosal surface. So this is a polyp, and since it has a peduncle, a stalk, and we call it pedunculated polyp. The other one in the picture is that it is a polyp that is protruding into the lumen of the gut. And it is again a stalk, so it is a pedunculated polyp, and it actually, it is grossly visible, and it can be removed by surgery. What is a colonic polyp? A colonic polyp can be, these are again the polyp, this one of the example. They protrude into the lumen and makes life miserable for the patient, although they are benign. A colonic polyp, the polyp has glandular tissue. Then what will we call as? It will be called as adenoma polyp because it has a glandular tissue. So you see that this is a polyp that is projecting, this is the mucosa, epithelium, and this is overgrowth extending above the mucosal surface. Yes, it has a stalk, yes. But again it has a glandular component. I'll show you how I focus here. See, this is a peduncle and this is a polyp. But the polyp has glandular component. You can see the lumen, you can see the epithelium surrounding the lumen, the basement membrane intact. So it is a adenomatous polyp. Coming to malignant tumors. As I told you, what is cancer is evolved from crab, it adheres, it invades the surrounding tissue, it invades the basement membrane, it can invade the lymphatic and blood vessel to spread to the distant size, that is metastasize, and it can cause death. So the designation malignant always raises a red flag. If you see a report of histopathology and they use the word malignancy, then it is alarming. It depicts cancer. Sarcomas have already explained to you that the malignant tumor lies in mesenchymal tissues. Sarcomas, again, a great word. They used to use it for fleshy objects like bulky objects. They are huge bulky tumors. For example, fibrosarcoma, chondrosarcoma, leiomyosarcoma, rhabdomyosarcoma. Blood malignancies, I told you, if they are coming from the malignancies arising from the blood-forming cells, that is the RBCs or the stem cells, the colony cells which are forming these RBCs and platelets, they are known as leukemias. So normal blood cells, but if you see the leukemic cells, the white blood cells, they are turning into blast cells, that is larger cells, bigger cells, and abnormal architecture, abnormal function, so we call them leukemic cells. Lymphomas. Tumors of lymphocytes are the precursors to any organ which has lymphoid tissue, say for example spleen, say for example thymus, say for example any lymph node. If the tumor is arising from that particular lymphoid tissue, then it will be known as lymphoma. Carcinomas, I've already explained to you that the malignant neoplasms arising from the epithelial cells. And they are derived from any of the three chambers. It is ectoderm, endoderm, and mesoderm. So once again, the carcinoma, as I just explained to you, if you remember from the previous slide, this is a picture of an adenoma because it has a glandular component. But what is this then? Are they glands? Yes, they are glands. They have a lumen. They are surrounded by epithelium. But what is happening to the architecture? There is sometimes you cannot find a good basement membrane around them. Now they are dedifferentiated. Here the cells are uniform. They resemble the normal glands of the GIT. But do these glands resemble the normal epithelium of a gland in the gut? No, they don't. You can see lots of mitosis over here. You can see a very vast, architectural differences between these cells and these cells. So this is a carcinoma, and since it is arising from the glandular type of cell, we call it adenocarcinoma. So carcinoma arising in ectodermally dry epidermis, they can arise from mesodermally dry venous tubules, they can arise from endodermally dry lining of the GI tract, or termed as carcinomas. Okay, now for the classified. If it is arising from skin or mucosa, which is lined by stratified squamous epithelium, then it will be known as squamous cell carcinoma. Cancer in which the tumor cell resembles stratified squamous epithelium is the squamous cell carcinoma. For example, it's oncogenic squamous cell carcinoma in the respiratory tract. So you see that this is basically the architecture of the stratified squamous epithelium taken from the epidermis. And this is the basement membrane. Okay, the basement membrane lies here, and these are the top. This is the top peritoneous layer. So if the tumor arises from this region and when it invades the basement membrane, goes into the dermis, from epidermis to dermis, then it is squamous cell carcinoma. As you can see in this micrograph, this is the epidermis and this is the dermis. But you see the next of the tumor cells resembling stratified squamous epithelium within the dermis. And if it is within the dermis, it means that there has been some invasion taking place. If there has been invasion, then it means that it is the carcinoma, not just the adenoma or the Lipoma. So it is the squamous cell carcinoma. Adenoma I just explained to you, just showed you a picture. It is arising from a glandular pattern. One of the examples, renal cell adenocarcinoma, you see the glandular pattern, the human lining cells, but the cells are dedifferentiated. So it is probably somewhere between 100 to 2 differentiated adenocarcinoma. Now what is mixed tumor? I explained to you what is mixed tumor. It is more than one type of cellular component, right? This is the salivary gland tumor mixed cell region, which is pleomorphic adenoma. It may have cartilage, it may have bone, it may have a myxoid, bluish myxoid stroma. It may have a glandular cell, it may have, sebaceous and secretory kind of activity cells because it is arising from a gland. But it is a mixed type of tumor. So this is one of the common examples is a salivary gland tumor, mixed tumor. And you can see some of these space cartilaginous cells, these are the cartilaginous cells, these are the fat cells, then smooth muscle cells, and maybe in a bigger picture you can see some secretory glandular architecture. So all of these elements arise from a single clone. They produce both epithelial and non-epithelial cells, and they are basically known as, this tumor is known as pleomorphic adenoma. It is a mixed tumor of salivary glandular tumor. Teratoma is again a mixed tumor, but as I explained to you that the component of this benign tumor, teratoma, is they arise from all the three germ layers, more than one germ cell layer. For example, originates from the pluripotential germ cells that are normally present in the ovarian testes. They don't find all the components of all the three germ layers anywhere in the body. Usually they are just found in the ovary cells or the testicular cells, the germ cells, but not anywhere else. But if they come together and form tumorous mass, it is known as teratoma. Now, teratoma can be mature and immature. If it is benign, it has all the benign components, then it is a mature teratoma. If it has immature components, then it is a malignant teratoma. So this is one of the microscopic pictures of the teratoma. You see the lining epithelium is stratified squamous, then you see a whole lot of cartilaginous tissue around. You can see thyroid tissue in here. You can see smooth muscle cells and some lymphocytes in here. So it's a mixed component. And they are arranged in all skeletal manner, not very regularly organized. They can form bone, epithelium, muscle, fat, even hair, tooth, as I just showed you in this picture. You can see hair and teeth arising from it. See, this is the hair and tooth arising from it. So usually it is known as ovarian cystic teratoma, dermoid cyst, because most of the time it is covered by skin and hair, so we call it dermoid cyst. Now, benign cystic teratoma can compose of skin and some adipose tissue, with sebaceous glands, and neural tissue. Exception of misnomer. Now, there are some exception of misnomers also in the known cluster of neoplasia. Lymphoma. Lymphoma is a suffix that we use for benign tumors, but lymphoma is never benign. Similarly, melanoma is a tumor that arises from melanin containing cells of the skin. We are using it oma, but it is never benign. It is a malignant tumor of the skin. And similarly, is a case of mesothelioma malignancy, which is known as mesothelioma, but it is a highly malignant tumor. Similarly, seminoma is a tumor that arises from the testicular tissue or testicular germ cells, but the suffix oma should not deceive you. It is a highly malignant tumor also. Hematomas are actually disorganized benign masses, and they have, cells that arise from the tissue from where they are arising from. So they are disorganized growth, but they can have glandular, they can have a muscle, they can have a bone, but they usually, composed of the tissue that is from the tissue they are arising from. But choriostoma is again a benign mass of a cell, but it is composed of a heterotropic edge. Let me give an example in choriostoma. Choriostoma, if you see in some patients, there is, within the stomach, there are nests of pancreatic tissue found. And the tumor that grows from there secretes a lot of pancreatic secretion. So when you remove the tumor and see under microscope, you see that instead of having or presenting stomach cells in that slide, you will see pancreatic tissue in that slide, and that is known as choriostoma. So some misnomers that were important to explain, so I just explained it to you. Now, we are just about to end this lecture. This is a summary of what we did today. First, we defined neoplasia, that is, it is an abnormal mass of the tissue. We did the classification, and we tried to understand how it is classified in neoplasia, and it is basically classified according to the parenchymal component. Then we have a benign kind of tumors and malignant kind of tumors. Benign tumors, they go within the capsule, they are not harmful, they are usually innocent, they do not invade and metastasize the surrounding tissue. And the malignant tumors, they invade and metastasize, they are very harmful, they can metastasize, they can cause death of a person. Now, benign tumors are usually well differentiated, and malignant tumors are usually dedifferentiated. Sarcoma is a malignant tumor of heavy bulk arising. It's a malignant tumor, it's arising from the mesenchymal tissues. Carcinoma is a malignant neoplasm of epithelial cell region. This summarizes it all. Thank you so much for your time. I hope that this lecture will help you understand the basics of the neoplasm. In the next lecture, we'll just proceed on to understand the gross and microscopic features of benign and malignant tumors. Inshallah, so see you there. I'm giving you some quizzes along with it, and please solve the quizzes and send back to me as it will be your assignment. It will be marked, inshallah. So I just check it and return it back to you also. But do attend the quiz after you completely understand this lecture and this portion of the book. Alright, see you again. Thank you so much.